Yeah. So good morning. Today I'm going to talk about the heart and lung interactions. It is a very core physiology topic, which is very important for intensivist, anesthetist, cardiac anesthetist, pulmonologist. Basically, very important in bedside, but it's very less talked upon in your training days. Might be difficult to understand if you try to read. So I'm trying to simplify in this lecture. So first of all, you should know certain things before going into directly jumping into the heart and lung interactions. Why heart and lung interact? Because they are present inside the same cavity, thoracic cavity. They act as a pump within the pump, and each of this pump are connected by means of pulmonary vessels. As you all know, there are some very confusing terminologies in this pressure. So main thing you should remember is something called as intrathoracic pressure. What is the pressure inside the thoracic cavity? So this is mainly contributed should be contributed by two things. One is the pressure surrounding the heart, pericardial pressure, and pressure surrounding the lungs, pleural pressure. So together, pericardial pressure and pleural pressure has to contribute to intrathoracic pressure. The thing is, normally pericardium is empty. There is no fluid. So generally, when we say intrathoracic pressure, it is going to be contributed only by the pleural pressure. So whenever someone uses the term intrathoracic pressure, it is the pleural pressure. Okay. So this pleural pressure is the pressure inside the pleural cavity surrounding the lungs is usually -5 at expiration and becomes more negative in inspiration. Next, one more confusing thing is transpulmonary, transthoracic, all those trans. So trans means pressure difference between the inside of something and the outside of something. Okay, so when I say transpulmonary pressure, pressure difference between the inside the pulmonary cavity and outside the pulmonary cavity. What is inside the pulmonary cavity or alveoli? So alveolar pressure minus what is outside the pulmonary cavity? The pleura. Your pleural place or the pleural pressure or the intrathoracic pressure. Both are same. Okay. So alveolar pressure minus pulmonary pressure, pleural pressure is your transpulmonary pressure. Similarly, for transthoracic pressure, pressure difference between inside the thorax. Inside thorax is the intrathoracic pressure, which is your pleural pressure, and outside your thorax, which is atmospheric pressure. Okay. So something called as transmural pressure is there. Transmural pressure is nothing but intracardiac or intracavitary pressure. So when you say LV transmural pressure, it is the pressure difference between the pressure inside the LV and pressure outside the LV. So left ventricular pressure minus the pressure outside your heart is your intrathoracic pressure. This is your pleural pressure. Okay, similar for RA transmural. RA pressure minus pleural pressure or intrathoracic pressure. So you know that venous system is a capacitance system means it is highly compliant, can accommodate large volume. So about 70 to 80% of the total blood volume is in the venous system. Okay. So among this total venous volume, or in fact among the total volume of blood in the body, there is some amount of blood existing even when there is no cardiac output. Even when the heart is not pumping, even in cardiac arrest state, there is some amount of blood present through the circulation. This is called the unstressed volume. Okay. So unstressed volume is the blood volume inside the vessel without generating any pressure on the vessel wall. Okay. Whereas stressed volume is that volume of blood that exerts pressure on the vessel wall. Okay. So if you see where is this unstressed volume? Predominantly in the venous system where the unstressed volume is high, whereas the stressed volume is very high in the arterial system. Okay, so the heart generates a pressure gradient between the arterial and venous system. Because of this pressure gradient, everything is possible. There is a cardiac output and there is a venous return back to the heart. What happens if there is no pressure gradient? What will happen? Will there be any blood flow? Okay, in a zero flow state, when there is a cardiac arrest state, some amount of blood needs to be still present in the circulating system. This blood volume exerts a pressure on the vessel wall. Okay, so this pressure generated when the entire blood flow is zero in the circulatory system is called the mean systemic filling pressure. It is just the pressure needed to fill up this systemic circulation. Okay, so mean systemic filling pressure normally it is around 7. Okay, so now you tell me if there is a mean systemic filling pressure is mainly contributed by the uh, unstressed volume, right? So what should be there if the blood has to flow actively? So mean systemic filling pressure is when there is no flow, no blood flow. In case blood should flow towards the heart. Okay. And what should be that? There should be something called a stressed volume. So normally unstressed volume is there. Above and beyond this unstressed volume, there is some amount of blood that is a stressed volume which actively contributes to the blood flow. Blood flow, by blood flow I mean contributes to the venous return to the right atrium. So if you see, the main determinant of venous return is the stressed volume in the venous system. Okay. Stressed volume which touches the vein contributes to the venous return, contributes to the mean systemic filling pressure. Okay. In zero flow state, normally unstressed volume is there. No pressure is generated. Only volume is there. But in case it needs to generate a pressure and propel the blood towards the right atrium, you need a stress to volume in the venous system. Okay, this is the formula. Stress to volume in the artery plus stress to volume in the vein divided by compliance of artery and compliance of vein. What happens to stress to volume in the artery? In a zero flow state, whenever there is zero flow, it means the pressure difference between the artery and vein is equilibrated. When there is no pressure gradient, it is equilibrated. Most of the blood volume tends to be balanced between the artery and vein. Is it? No, most of the blood will be going to the venous system in zero flow state. Okay, pooling of blood in the compliant venous system. So in such a case, the stress to volume of artery do not matter in a zero flow state. It is a mean systemic filling pressure. So mainly the stress to volume of your venous system contributes to this. And your arteries are not very much compliant. So predominantly mean systemic filling pressure and venous return is by the venous stress to volume. Okay. So next, coming to this, your right atrium and right ventricle anatomy and physiology is in such a way that pressure generated inside the RA and RV is always lesser than the pressure generated in the systemic circulation. This is what your systemic veins, your mean systemic filling pressure. The pressure generated in RA and RV is always lesser than the pressure generated in the MSFP, mean systemic filling pressure. So this creates a pressure difference, otherwise called as pressure gradient. And this pressure gradient is what causes the venous return to the right side of the heart. Okay, why? What is this special about anatomy and physiology? It is a very thin walled chamber, and it only has to generate very less pressure to propel the blood into the pulmonary system because this is a very low vascular resistance system. So it only has to generate very less pressure. Okay, because of this, this pressure is much lesser than the mean systemic filling pressure. So this is the table explaining what happens to the stressed and unstressed volume in certain conditions. Suppose patient is having hypovolemia. Hypovolemia, example, dehydration or any hemorrhagic shock. From where does the blood get lost? Stressed volume or unstressed volume? It is the stressed volume. Why not from the unstressed? Because I told you, even in zero flow state, there is some amount of blood in the vessel. That is unstressed volume is still present even in zero flow state. So this does not change. This does not get reduced, especially the stressed volume which is getting reduced. Net effect is decrease in the mean systemic filling pressure. Opposite happens in case of fluid bolus administration or hypervolemia. Unstressed is still the same. Only the stressed volume is increasing when you're giving a fluid bolus. Total blood volume is overall increasing and increasing the mean systemic filling pressure. Now, depending on what happens to the arteries, uh, we'll see what happens. So, when there is a vasoconstricted state of the arteries, what is happening is since the arteries are constricted, blood cannot freely flow from the venous system to the arterial system because the pressure is high here. Then what happens? Pressure is back transmitted, and this unstressed volume is get shifting to the stressed volume. Stressed volume of the venous system is getting shifted to the stressed compartment of the venous system. Net effect in total blood volume, any change? No. What happens to the reservoir? By reservoir, I always mean the unstressed volume contributes to the reservoir. Okay. Net effect is increase in the mean systemic filling pressure. Exactly opposite happens in the stressed in a vasodilatory state. Stressed volume is decreasing and unstressed volume is increasing. Okay. So this is the formula for venous return. Difference between the mean systemic filling pressure and the right atrial pressure. Mean systemic filling pressure minus the right atrial pressure divided by resistance to the venous return. This venous return experience resistance at three levels. First level in the abdomen. Abdomen, if the intra-abdominal pressure is high, they experience a resistance. Next is the intrathoracic resistance. Another is the pulmonary circulation resistance. So it's inversely proportional to the venous resistance. Clinical importance is that in case of intra-abdominal hypertension, abdominal compartment syndrome, the venous return resistance is very high, and because of this, the venous return is basically reduced. So someone they plotted a curve of this right atrial pressure and venous return. So this right atrial pressure or the mean systemic filling pressure is in the x-axis, venous return is in the y-axis. Okay, you see in this curve, as the right atrial pressure decreases, forget the colors, I'll explain it later. As the okay, let's take this black curve, which is normal. As the right atrial pressure keeps on decreasing, your venous return is increasing till a point of zero, till the right atrial pressure is zero, after which it becomes negative. After this point, venous return cannot increase. Why is this? Because as it becomes less or more negative, what happens? Because of the negative pressure generated, hmm, because of negative right atrial pressure and right intrathoracic pressure, collapse of the great veins, that is SVC and IVC happens. This is called vascular waterfall phenomena. Because of negative pressure generated, the vessel walls collapse, sucked out. Beyond this point, more blood cannot be sucked out as they are already collapsed, and beyond this point, there is no venous return. So beyond the negative pressure of right atrial pressure, no more, no matter how much you try to give the fluid, it will not contribute to the venous return. Okay. So what happens when you give a fluid bolus or hypervolemia? There is a rightward shift of the venous return curve. Right atrial pressure increases and venous return increases. Similarly, in hypovolemia, leftward shift, right atrial pressure decreases and your venous return decreases. Another interesting clinical scenario. Let us take two scenarios. Okay, so this looks confusing, but I'll explain to you. This is nothing but the similar curve, the same curve. Right atrial pressure, venous return, and cardiac output. These blue lines is the venous return curve. Red lines are the cardiac output curve. Okay, so they have explained two conditions here. First, we'll see what happens in sepsis, early distribution phase. Okay, the venous return curve. hmm, So we'll see what happens in the septic shock. There is a cytokine storm causing profound arteriolar vasodilatation. So what happens in the vasodilated state? I told you. See here, in arterial vasodilatation, the resistance to the venous return is reduced. Okay, once the arterial vasodilatation happens, the resistance to this venous return is reduced. What happens if this is reduced? If denominator is reduced, the venous return is going to increase. That is exactly what happens in the septic shock. Okay, drastically lowers the resistance to venous return, allowing blood to rush back to the heart. That is the curve here. See, in arterial vasodilated state, the reduced resistance to venous return causes the venous return keeps on increasing, going upward. Okay, whereas in unresuscitated sepsis, okay, if there is not adequate resuscitation done, blood is pooled in the venules and they start leaking into the interstitium. This causes the mean systemic filling pressure to reduce and the line is shifted leftward. Okay, see, if patient is not getting resuscitated, there's a leaking of this blood venous system into the interstitium. Sorry for that. So what happens in the cardiac output curve in the sepsis? So remember, sepsis is because of catecholamine surge. It is having a increased cardiac sympathetic stimulation that way causing the cardiac output curve to shift forward and leftward. Okay. So there is something called the equilibrium intersection where the venous return curve and cardiac output curve intersect. So what happens? Net effect is cardiac output is elevated with low to normal light atrial pressure. Cardiac output is elevated. Where is it intersecting? Here. Or it can either be low if it is unresuscitated or normal if it is adequate volume is there. Okay. So what will happen here? This is what we call as wet shock. Cardiac output is reduced, but it is not due to lack of blood flow or due to cardiac this thing, lack of flow. It is mainly because of vasodilated states, causing the blood to be shunted past the capillary beds. So, it's a cardiac high cardiac output failure, which is occurring sepsis. This is what we call warm wet shock. Okay, warm because there's sympathetic stimulation, wet because see venous return is high. It's a leaking into the interstitium. Okay, next is decompensated heart failure. What happens in a decompensated heart failure? Cardiac output is reduced. So the cardiac output curve is shifted to the downwards and towards the right side. What happens to the venous return curve? Venous return curve. See, basically in cardiac failure, there's an increase in RAS, renin-angiotensin aldosterone axis, which causes water retention. Once the water retention is there, the right atrial pressure is increased. Right atrial pressure is increased, the venous return is also increased because of the stretching of right atrium and elevated right atrial pressure. There's a back pressure changes leading to features of right heart failure. That is your elevated JVP, hepatomegaly, and pulmonary edema. Okay. So there are some factors which determine the LV afterload. Remember these two laws you have to know. One is the Frank-Starling law and Laplace law. Frank-Starling law states that the force of contraction is directly proportional to the initial length of muscle fiber under normal resting state in normal heart. Okay. Laplace law, that is LV afterload or wall stress is equal to the LV transmural pressure. That is the pressure difference between the inside of the ventricle and outside of the ventricle and ventricle radius. The radius of ventricle determined by the left ventricular end diastolic volume, and H is the wall thickness. This is a non-modifiable factor. So now you tell me what happens when there is more left ventricular end diastolic volume, more stretch on the left ventricles, and increased preload causes more force of contraction. This is by the Frank-Starling law. On the other hand, more left ventricular end diastolic volume, more is the ventricular radius. More is the radius. What happens to the wall stress? Directly proportional. Wall stress or afterload increases. So afterload is also increasing. So what will happen? So under normal heart, the increase in left ventricular preload, huh, the increase in left ventricular preload overcomes the increase in afterload. So net effect is cardiac output might increase. But in case of failing or dilated heart, afterload increase overcomes the preload increase. Okay, so the cardiac output might fall. So now we'll see about heart-lung interactions. Okay. So under normal conditions, sorry, excuse me. Under normal conditions, the pressure changes and volume changes happening inside this chamber are very much less transmitted to the lung. Okay. Lung and chest intervene in this transmission. Whereas in certain cases where the lungs are highly compliant, like in COPD or asthma, or in case of collapsed lung in ARDS, pneumonia, pneumonia, or if the chest wall is non-compliant, then this pressure and volume changes are transmitted to a greater extent to the heart. Okay. So what happens in spontaneous breathing? Hmm? So when there is a spontaneous breathing, okay, the diaphragm is being pulled down. It generates more negative intrathoracic or intrapleural pressure. More negative the intrathoracic pressure, more negative the right atrial pressure. If this becomes more negative, what is the formula for your venous return? Mean systemic filling pressure minus RAPS become more positive. Okay. So suctioning effect, can I remember it by two ways. Spontaneous breathing, negative intrathoracic and negative right atrial pressure, suctioning effect. Otherwise, remember this formula. Mean systemic filling pressure minus RAP. Minus minus is plus. So your venous return is increased. Increased venous return means increased RA preload. Increased RA preload is increased RV preload. Increased RV preload means increased RV output. Where does this output go? Okay, this output goes to the pulmonary circulation. So in normal conditions, remember this RV output which is going to the lungs is held in the blood is held in these vessels, extra alveolar vessels. Whereas if deep forceful inspiration occurs, such as when patient is in distress, what happens? The RV is greatly distended. Beyond this point, it cannot get distended inside the pericardium. So little bit of this interventricular septum is being pushed towards the LV. Because of this, the preload to the LA and LV is reduced. This happens only in deep forceful inspiration. Okay. But next we'll see what happens to the left ventricle in case of spontaneous breathing. As I told you, the left ventricular transmural pressure is difference between left ventricular pressure and intrathoracic pressure. That is the pleural pressure. So when patient is breathing normally, minimal changes happen. But when patient is in distress, such as pulmonary edema and anything, very high negative intrathoracic pressure is generated. So this negative becomes positive. So high transmural LV pressure causes increase in LV afterload. When LV afterload is increased, obviously reduced cardiac output. So this is more significant in cardiac failure. These patients should not be allowed to get a very high negative intrathoracic pressure, such as in pulmonary edema, etc. So avoid this large swings in pleural pressure. Okay. So this reduction in the cardiac output causes that is the reduction in blood pressure is usually less than 10 millimeter mercury during inspiratory phase. If this falling BP is more than 10, it's called pulsus panicis. Exactly opposite happens in mechanically ventilated patient. Instead of falling, the cardiac output and blood pressure increases. This is called reverse pulsus paradoxus or respiratory paradox. Okay. So next we'll see what happens to the in case of positive pressure ventilation. Okay. So first we'll see what happens to RA RV preload. Positive pressure ventilation, there is a positive intrathoracic pressure, raised right atrial pressure. Raised right atrial pressure means the gradient between this and this is reduced. So reduced venous return. Reduced venous return means reduced right atrial preload, reduced right ventricular preload. Okay. Because of positive pressure ventilation, the venous return is reduced and reduced RA-RV preload. Okay. Next, what happens to RV afterload? Mhm. Okay. That's a very good image. So inside these lungs, you see there are two types of blood vessels. One is the alveolar vessels, alveoli. Just surrounding them is alveolar vessels. Beyond this point, extra alveolar vessels. So when the alveoli is collapsed, these alveolar vessels are nice. Okay, they don't experience any compression by the alveoli. Blood flow is good, so resistance in this is good. The same condition, what about the extra alveolar vessels? That is before the expansion of alveoli. This extra alveolar vessels over here, they look tortuous. Okay, which means they're a little bit collapsed and they generate more resistance in these vessels. Okay, now exactly opposite in the when the alveoli expand. When the alveoli expand, alveolar vessels are compressed. But these extra alveolar vessels, instead of being tortuous, they become more straight. The traction effect is there. So blood flows more easily and the resistance is reduced. Okay, so extra alveolar vessel is this blue line. Okay, if the alveoli is not expanding, if it is fully collapsed, means the lung volume is closer to the residual volume. Look where the pulmonary vascular resistance is. So extra-alveolar vessels, when the alveoli is collapsed or tortuous, experience resistance, so high pulmonary vascular resistance. Once they start expanding, once the alveoli start opening up towards the functional residual capacity, look where the pulmonary vascular resistance is. It is in the sweet spot, normal. Okay, here, look here, beyond a certain degree, when it's over expanding, pulmonary vascular resistance drops. The danger is in such condition, if they cause a vasoconstricted state. Okay, over distension. I'll tell you how harmful it is. Okay, what happens in the over distension state? This is the alveolar vessels. They cause increase in pulmonary vascular resistance. So you don't want the alveoli to be expanding in a rate of here, where it is harmful because of effect of alveolar vessels. Same time, not here because of harmful effect of extraalveolar vessels. The bimodal curve, U-shaped curve of the pulmonary vascular resistance. Sweet spot is somewhere when you're ventilating at the functional residual capacity. Concept is simple. Alveoli collapsed. Alveolar vessels are nice and good. Less pulmonary vascular resistance here. In the low volume, functional residual capacity. The alveoli is collapsed. But same, what happens? Extraalveolar vessels, when their alveoli is opening up, they are better, not when they are collapsed. Okay, they have more resistance here. Okay, so where were we? We saw what happens to positive pressure ventilation, RA-RV preload. Now we should see what happens to the RV afterload. So positive pressure ventilation, alveoli expand, alveolar vessels are compressed, and extra alveolar vessels distend. This is what I showed you. So there is increased alveolar vessel resistance and decreased extra alveolar vessel resistance. Net effect on pulmonary vascular resistance depend upon lung expansion. So angle inflation we saw here the residual volume. Okay, here the residual volume it is there. So this thing is there is a reduced. There is increased pulmonary vascular resistance. Because of this, there is increased RV afterload. So RV output is reduced. When you give positive pressure ventilation in such cases, when the alveolar is collapsed near the residual volume, alveolar recruitment happens and open up the extra-alveolar vessels. This relieves the hypoxic pulmonary vasoconstriction and reduces the pulmonary vascular resistance. Because of this, RV afterload is reduced and increase the RV output. What happens in over distension? High PEEP, near total lung capacity, increased peripheral pulmonary vascular resistance, predominantly because of, see, alveolar vessels contribute to the raised pulmonary vascular resistance. They're fully collapsed. Right? So there is increased RV afterload and reduced RV output. So sweet spot is near the functional residual capacity. So for net effect, what happens? Even though this positive pressure ventilation can open up extra alveolar vessels and may reduce pulmonary vascular resistance, RV output still drops because positive pressure ventilation causes massive drop in RV preload. Okay, the positive pressure ventilation, RV preload is reduced venous return. Because of this, the net effect is RV output is going to be reduced. Okay? And some amount of blood is also squeezed from the lungs towards the pulmonary artery, and the west zone is created in the lung one because in the lungs. Because of this, RV afterload is reduced. Net effect is reduced RV preload and increased RV afterload. Because of this, net effect of RV is reduced output. Next, coming to left atrial preload. Okay, similarly, positive pressure ventilation, blood squeeze to the left atrium, increased left atrial preload, and increased left ventricular preload. Next, coming to left ventricular afterload. Positive pressure ventilation, increased intrathoracic pressure, and afterload is this because of this transmural LV pressure is reduced. Okay, what is the formula? Left ventricular pressure minus intrapleural pressure. This is getting high, so this difference will be reduced. So left ventricular afterload is reduced. Increased cardiac output during inspiration is because of combined effects of reduced LV afterload and increased LV preload. So this one thing summarizes the entire heart-lung interactions. So basically, I'll tell you, doing positive pressure ventilation in case of inspiration, what is happening? Okay, what is happening is here in inspiratory phase, there's reduced RV pre and increased RV after. Because of this net effect of reduced RV output. Same time during inspiration, what has happened to the left ventricle? Reduced LV afterload and increased LV preload, causing an increase in LV stroke volume. So this is showing some pulse pressure is maximum at the time of inspiration. Okay, so you may think there's a reduced stroke volume from the RV, reduced RV output. Then how LV is getting increased preload? That we saw is because of the increase in pulmonary vascular resistance. Okay, so shouldn't the reduced RV output cause reduced in LV out? Yeah, it happens, but it does not happen immediately. Okay, inspiration, there's reduced RV output and increased LV output. This reduction in RV output will take some time before it is showing its effect on the left ventricle. This effect of right ventricle on the left ventricle output is called ventricular interdependence in series. This change will usually take some time, about 2 to 3 heartbeats later. This is called the blood pulmonary transit time. The RV output has to go through the lungs and then enter the left ventricle. Okay. So this it's called blood pulmonary transit time. So this happens after 2 to 3 heartbeats. Beyond this, there is a effect of RV seen on the LV. So reduced LV output, sorry, reduced RV output is seen as reduced LV output. This happens after 2 to 3 beats, called pulmonary transit time. By this time, patient would have entered the expiratory phase. So this reduction in LV output is only seen in the expiratory phase. So pulse pressure is minimum in the expiratory phase. This phasic variation is what we call pulse pressure variation. Okay. Net effect of reduced LV preload and LV stroke volume during expiration is called pulse pressure variation. So next is, yeah, we saw ventricular interdependence in series is RV output influencing the LV output happening in a continuity called a series. Something called interdependence in parallel. This is because of the common interventricular septum and myofibrils which they share. In case of RV dysfunction or pericardial pathologies, the septum is shifted towards the LV, reducing its compliance and output. Okay, this is worsened by positive pressure ventilation. Blood pulmonary transit time, which is 2 to 3 beats later, is seen, right? This is because of interdependence in series. But if interdependence is happening in parallel because of some pericardial pathologies, RV pathologies, there will not be any transit time. It instead will be immediately. Immediately upon initiation of mechanical ventilation, you can see the uh, drop in the cardiac output. Okay. So other things which we must consider or which we must know is when we are ventilating with a high tidal volume, there's increased vagal tone and causes bradycardia. Whereas in lung protective this thing, the inhibition of vagal tone is there. And similarly, you may have seen after intubation, immediately after intubation, some patients may go for cardiac arrest. Normal euvolemic or hypervolemic patient, when the positive pressure is initiated, the increase in right atrial pressure is matched by the increase in mean systemic filling pressure. Both of them are increased. Okay. So there is no drop in venous return. When does this happen? In euvolemic or hypervolemic patient. Why does this happen? If the venous reservoir is adequate, the diaphragm compresses the splanchnic circulation and they manifest as venous return. Okay, but in a hypovolemic patient, increase in intrathoracic pressure drastically reduces the venous return and BP. That's why some patients crash when after intubation. Okay, and similar effects, clinical importance during weaning. Okay, when the patient is going to, from mechanical ventilation to spontaneous breathing, venous return falls because the negative intrathoracic pressure is generated when the patient breathes spontaneously. Venous return is, venous return increases. The gradient is increased and venous return is increased. An increase in pulmonary vascular resistance and increase in LV afterload, just like what happens in spontaneous breathing, the sudden gush of venous return. If the patient LV is not proper, if there is impaired LV function, patient may go for pulmonary edema. Okay. Such cases, you have to give positive pressure ventilation by NAB at least. Okay, so this is the summary of heart-lung interactions, which you should know. If any doubt, please let me know in the comment.